So with that, I'd like to begin with the discussion on the solid pulmonary nodule, and I'd like to first disclose my speaker honorarium from Siemens Medical. And with that, we'll move on to our objectives for this session. And my objective is to discuss a little bit about nodule detection on CT, focusing on the solid lesions, discuss non-invasive characterization techniques such as growth, PET-CT nodule enhancement, and cover some pitfalls that can occur when evaluating pulmonary nodules. And lastly, summarize where these non-invasive management techniques fall within guidelines issued by clinical societies such as the American College of Chest Physicians and the Fleischner Society. I'll be focusing on solid nodules, and you hear a great discussion on subsolid lesions after me. So first, in terms of nodule detection on CT. Where are the nodules that we are overlooking? Well, they tend to be central, adjacent to vessels, adjacent to other pathology. They tend to fail to abut the pleura. The central lesions are more challenging for us. I think we do focus a lot in terms of the periphery of the lungs when we search for nodules. Low attenuation lesions, not surprisingly, sometimes due to their small size and partial volume averaging. So how can we improve our detection of lung nodules? Well, maximum intensity projection imaging is something that can be utilized. It's an additional reconstruction series from the CT scanner or done using software and computer-aided diagnosis, which has been primarily approved for solid lesions. So here's an example of a nodule that can be challenging. It's located adjacent to a vessel in the central area of the lung. This is a thin section image, and it looks very similar to other nodules on the same axial section. Well, MIPS is something that basically takes the largest or the brightest voxel along an array within a slab of an image and displays that, and therefore you see the vessels and their course much easily on an axial MIP and easily differentiate nodules, or better differentiate nodules from the adjacent vessels. So Gruden and colleagues did study the value of MIPS and did show that central nodules were improved using MIP analysis or MIP images by all readers in the study. And even for the junior readers, MIPS helped for detection of the peripheral nodules. And they concluded that MIPS can decrease the number of overlooked small nodules, but nodule detection is still imperfect. So now in terms of MIP thickness, what is the best thickness for MIPS? This investigation in the AJR showed that looking at 5, 8, and 11 millimeter sections, they identified that 8 millimeter sections were the best for improving the ability to pick up lung nodules by radiologists. Now here's an example of a nodule that is in a location that can be tricky. It tends to be our blind spots are anteriorly adjacent to the mediastinum, hilum, tucked medially, posteriorly, and in the back. And this nodular density was a nodule that was not initially detected. We can see the CAD mark indicating the nodule. This is a nodule that is tricky for us, and CAD can help. CAD is also challenged by the vessels in the central regions, but it's been shown that with the use of CAD in conjunction with readers, with CAD as a second reader, that the sensitivity for lung nodule detection improves. And this was a study by Das and colleagues in radiology with 2 commercially available devices at that time. And they looked at thin section images and had their readers evaluate these, and then had them evaluate the same images with the CAD devices, each separated by a time period so that they didn't remember nodules. So they first looked at images with MIPS, then they looked at images MIPS plus CAD1, images MIPS plus CAD2, and then they looked at the sensitivities. And these are the sensitivities of the readers with the addition of CAD, and we can see the asterisk to note the increased sensitivity for lung nodules with CAD. Now that was for solid nodules, and subsolid lesions with CAD are to a lesser degree not investigated, but as we are aware more of subsolid nodules, we'll see more of the devices directed towards these. Now to touch on CT protocol. In terms of CT protocol, radiation dose is of high importance We reduce our radiation exposures for patients undergoing evaluation for suspected lung nodule on chest X-ray, and also for follow-up of CT-detected lung nodules. And this is something that we have integrated into our clinical protocols and nodule follow-up algorithm or protocol. Tube current modulation is something that we always use, and basically the X-ray tube is modulated, or the beam is modulated in terms of the overall MA to maintain image quality and minimize the amount of radiation. So thicker areas of the thorax receive greater MA as opposed to thinner areas of the thorax. Typically, CTs are non-contrast, and the IV contrast really isn't necessary in most cases. And thin section imaging, I think we'll emphasize, really helps us assess morphology, really look at subsolid lesions, which we'll hear more about, and assess the attenuation of these lesions. A soft tissue algorithm is something that if we suspect fat is present in the lesion, we have these series reconstructed in thin sections to see and better assess with more confidence for the presence of fat. Now, in terms of iterative reconstruction, I think you all, if you do have this available, probably have implemented it, but this is just an example of the image noise when imaging at low-dose CT levels. And this is filtered back projection, which we traditionally had utilized, and the different degrees of iterative reconstruction from lower to higher that can be applied. And with that, there is some dropout in the spatial resolution of images, but you do have overall reduced image noise that might help nodule conspicuity for nodule detection. So the exact value or the amount of iterative reconstruction really depends a certain amount on radiologist preference, but I think it's just important for us to be aware that there are different degrees and they are tailorable to a certain degree depending upon the manufacturer. And more helpful in terms of evaluation with iterative reconstruction is the soft tissue windows. It really helps us in our screening studies to reduce that image noise, apply it, and clean up some of the areas such as in the liver that are more harder to evaluate. Now with multi-detector CT, we are able to evaluate the nodule in 3 dimensions. And with this data, we can look at an image in the axial section. However, we can also obtain coronal images or sagittal, in which we have another view of a nodule, and we can better assess its overall shape and morphology. And we can see on the current and the prior comparison, we may not detect such an apparent change in a nodule, which may be more apparent in another plane. So let's take another look at an example in which there's a nodular density in which we think is a nodule and would call a nodule. But when we look at on coronal section, it's a linear opacity. This is what we would call a scar. So something that looks like a nodule in one plane may well be easily characterized on another plane. So 3D volumetric data is helpful for nodule characterization. So now moving on to nodule morphology growth, some PET-CT and nodule enhancement techniques. I'll be focusing on the solid lesion, which is soft tissue, usually completely homogeneous as opposed to the subsolid nodule. So the differential for the solitary pulmonary nodules is typically granuloma lung cancer and solitary pulmonary mets in the right patient, hamartoma carcinoid, AVM. So these are the main things that we think about. There are some more obscure entities, but these are the main players, the top two probably the main things we deal with. And there are calcification patterns that have been correlated with benign etiologies, and these are termed benign calcification patterns, the homogeneous, the lamellated, which is the whorled appearance, the central calcification that occupies a predominant amount of the nodule, and the popcorn associated with hamartomous calcification as opposed to granulomatous patterns on the left and centrally. Indeterminate patterns are when we have this speckled calcification, which arise from dystrophic calcification within a tumor or a calcified granuloma that has been engulfed by a lesion. Any eccentric calcification is termed indeterminate. This speculated nodule can be characterized further with the use of thin section soft tissue algorithm images, the reduced image noise. We can see the fatty attenuation within the lesion. This patient had these large densities with some fat, had lipoid pneumonia, but we can nicely say that this nodule was part of the lipoid pneumonia due to the fat. And fat differential is that of a hamartoma, lipoid pneumonia, and liposarc. Of course, clinical history is key. The hamartomas, as we can see in this example, tend to have a lobulated border, well circumscribed, smoothly marginated. These lesions derive from connective tissue in the airways and have fat and calcification related to cartilaginous tissues. And not surprisingly, they demonstrate fat and calcium, particularly when they're large. And the key aspect is fat is perhaps the most common helpful imaging finding, as shown by Siegelman in this paper in Radiology. And calcium is something that is helpful, but oftentimes is not present as often as fat. So now what about nodule location? Well, periphyseal nodules, I think we've all heard recently, particularly in the screening trials, have been associated with benign lesions. And we'll go into more detail about what a periphyseal nodule is. This Nelson screening trial had a good amount of periphyseal nodules, and they showed upon follow-up that none of these were malignant. And these periphyseal nodules even demonstrated some growth. And the reason why is these probably correlated with intraparenchymal lymph nodes, which is lymphoid tissue that can grow and increase when inflammation is present. And this is just an example of a diagram from their manuscript showing what they considered a periphyseal nodule. Their nodular density is centered along a fissure. They should be elliptical with obtuse angles, or polygonal, abutting but not extending very much beyond the other side of the fissure. And we can see these are lesions that we shouldn't be calling periphyseal nodules, round lesions that are eccentric in relation to the fissure. And here are some examples of nodular densities. This perhaps is just thickening, which we do see. This is one of those which you might debate as a nodule, but has obtuse angles regardless, probably not significant. And these are the two areas that would be kind of characterized as a typical periphyseal nodule, abutting the fissure on one side with mildly obtuse angles and or polygonal structure. Now this nodule is an example of how morphology and shape can help. We can see that there's some respiratory motion, but this nodule is on multiple axial sections. And it almost has this tubular component. And another clue is that the airway is seen right next to it and it's normal in caliber, because oftentimes we can wonder, is this mucoid impaction? And more likely it is that. But when we see a normal small airway next to it, that means the airway is preserved and normal. So this was questioned to be a vascular lesion and was shown upon contrast-enhanced CT to represent a small aneurysm, pseudoaneurysm, probably from a prior Swan-Ganz catheter at some point. So this is a pitfall. We don't want to be diagnosing lesions as a nodule that's a soft tissue nodule that's cancerous, or perhaps a granuloma, something that could be biopsied when it's vascular. So now in terms of margin and size, I think this is something that has been discussed to a large amount of degree, and I think we all know that lobulation and spiculation is something that we worry about cancer with, and particularly size. Size is one of the main predictors for malignancy. And so we'll go and talk about automated nodule volume measurement. And this is because there's more attention in terms of measuring nodules. And there are some commercially available software packages that have been investigated and compared by DeHoop and colleagues. And they've shown that there are some variabilities in the software packages. Perhaps they're not always utilized fully because they're not integrated in our PACS reading system. But basically about 20 to 30% volume change is probably the limit for variability, and anything more than that is more of an indicator of a true change in size. So that's something that needs to be done with any software program, is to assess what's the limits for how well can we detect change in size, and how does that manifest, and how do we determine that true growth has occurred. And for this reason, these software packages, one of them has been integrated into the Nelson trial. And with this, the Nelson trial tried to use size as measured by automated measures as a predictor of malignancy. And they looked at intraparenchymal nodules, none of those periphyseal nodules. They basically separated it out. Sorry, the timer's beeping. No, it's okay. But they basically tried to take away those periphyseal nodules and look at the purely intraparenchymal nodules. And they basically took the nodules and measured their volume and basically followed these lesions and showed that the tumor volume on the initial CT was the main determinator for what proved to be malignant. And that's not surprising. We know nodule size is very important. Lobulation and spiculated margin surprisingly didn't really prove to be as significant factors. So that's why size is really one key aspect that remains the major determinator for what is malignancy. And that's why they've been integrated into management algorithms. So now moving on to nodule growth. Nodule growth, once we measure size, can be compared over time. And change in nodule size over time can be used as a way to differentiate malignant from benign. In terms of solid cancerous lesions, we typically think of volume doubling times on the order of greater than 20 days and less than 400 days, as shown in this study looking at small cancers detected on screening. The subsolid lesions have longer doubling times, which we will hear more about. So in terms of doubling times, I think we're going to be hearing a large amount of this more with screening. And this is the Nelson trial data, which they recently published in Lancet Oncology, and showed that you can differentiate patients who have different probabilities of developing cancer. If you have a volume doubling time greater than 600 days, probability of malignancy 0 to 1%. 400 days or less, much higher volume likelihood of developing cancer. So not surprising, because we've known in the past that 400 is a good cutoff. And they do suggest that the volume doubling time can be useful for characterizing those intermediate size nodules. So a couple of pitfalls, images from a patient who had a nodule and was shown to decrease 5 months later. However, it's helpful to know that these nodules could potentially still be malignant and thus need to be followed to long-term stability or resolution, even if they initially decrease. As this case, the patient's nodule ultimately increased, and this was a cancer. So another pitfall can occur is when we see these cystic areas in the lung, which can easily be a small cavity. There is some thickening around the wall, but nodularity, if is seen along the periphery of a wall, could well be an indicator of malignancy. And you can see this lesion progressed in terms of the solid area in the periphery of the cystic region, and this was proven to be an adenocarcinoma. So this is a manifestation of cancer growth more recently described by Faruqi and colleagues, and can be a number of histologies associated with adenocarcinoma in particular. And so therefore, it's helpful for us to remember this pattern of growth. So in terms of PET-CT and nodule enhancement, PET-CT has been shown to be a useful tool for indeterminate pulmonary nodules. It's not something we routinely order all the time for nodule characterization particularly, but nodule enhancement is something that also could potentially characterize these lung nodules. So here's an example of a PET-CT of a nodule in the right upper lobe. We always think of cancer being hot on PET. This nodule was hot on PET, however, was biopsied and shown to be tuberculosis. And granulomatous disease is the one pitfall that, whether it's inflammatory or infectious, for causing false positives on PET. In terms of false negatives, they've been associated with carcinoid adenocarcinoma in situ and small lesions in particular. And here's an example of a smoothly marginated lesion that was PET negative but was followed up, showing how this intervally changed and was ultimately resected. And this is the pitfall of the carcinoid tumor, which is known to be PET negative a good amount of the time, particularly when typical. And so therefore we do recommend follow-up of benign lesions determined by PET to avoid false negative diagnoses for malignancy. So in terms of nodule enhancement, I don't think many of us perform this, but if you do, if you are in an area where you don't have PET-CT, this is something that has been investigated and is shown to have similar percentages in terms of sensitivity and specificity as PET. The low specificity is related to inflammatory disease that enhances similar to cancer and can be diagnosed as a cancer, therefore. And the pitfalls that exist with PET, there are also pitfalls that occur with nodule enhancement, particularly the necrotic lesions. Any lesion with calcification ground glass can lead to a problem, so it's not something that we typically would even think of doing for these lesions. This is just one example in which nodule enhancement was performed. It was a small lesion. It's on the order of 6 to 7 millimeters perhaps, and the nodule enhancement was shown to be 60. And this was kind of high, and so we thought that this could potentially be a carcinoid tumor. It was along an airway, and this was a small peripheral carcinoid upon resection. Now, well, it could be a granuloma, true, but in this individual, the suspicion with this morphology was that of a carcinoid given that airway location. Now, I brought up nodule enhancement because I think in the literature we've been seeing much more about dual energy imaging. And this is something that is still under investigation in terms of its benefit. But with dual energy imaging, we can look at nodules not only anatomically, but also identify the different components within an image that was obtained with contrast. And we can separate the image into its iodine and its non-contrast components. And in this case, this was a small nodule. The patient did have a history of melanoma. And we can see that the dual energy processing identified the pre-contrast values to be 20, so about soft tissue, and the iodine enhancement to be about 55. And this was a melanoma metastasis. So there is potential for enhancement assessment with dual energy imaging. And this was investigated by Che and colleagues, in which they looked at 3-minute post-contrast dual energy CT, and they did show similar results in comparison to nodule enhancement as I had just, Dr. Swenson and his colleagues had investigated, where they took a true non-contrast and compared it to post-contrast enhancement. This was just looking at the dual energy virtual non-contrast and iodine maps. So now on to management of solid nodules. We touched upon a large amount of techniques and ways to look at a lung nodule and how do these all fit into management algorithms. And therefore, I'd like to bring up this multidisciplinary paper by Gould and Patel and Dr. Nadic. This is just all summaries of multidisciplinary writing of management guidelines that the American College of Chest Physicians have published. And basically, it follows what we practice, I think, on a daily basis, is when we identify a lung nodule, either on a chest X-ray or CT, we immediately ask for old films. And if there's old films, it's very good, because for solid lesions, if you do have stability for more than 2 years, these lesions are more likely to be benign. For the subsolid lesion, this does not apply. And if we don't have comparison imaging, thin section CT should be performed to better assess a lesion's attenuation and features. And with multi-detector CT, this is something that we can do on a daily basis. Now, in terms of if the lesion's solid, we then ask, does it have benign calcification pattern, fat or vascular enhancement, or something that is suspicious for AVM? Then we can make the diagnosis. If not, unfortunately, which is most of the case, if you have a nodule and it's greater than 8 millimeters, you can consider further evaluation, and that is with the techniques we touched upon. PET, which is reserved in the ACCP guidelines for the low and moderate probability patients, and the high prob patients tend to directly go to some form of more aggressive biopsy, although they tend to oftentimes get PET if they're really suspicious for cancer, and that's really for staging. The intermediate probability group with PET, if you have negative uptake, this should go and get followed up, because we showed that carcinoids can be negative on PET. And if positive, these tend to be aggressively biopsied or surgically removed or minimally invasively biopsied, depending upon the institution. And of course, if biopsy is not diagnostic, follow-up is something that we've always been performing. So in terms of the nodules that are less than 8 millimeters, we apply the Fleischner guidelines. And I think we're all aware of the Fleischner guidelines, and it's based on a large amount of data. We've already touched upon some of the newer data about nodule size and the probability of malignancy. But you can see from this that the likelihood of malignancy, if you're dealing with a small nodule, is extremely low. And it gets higher as the nodule gets over 8 millimeters. So that's why the Fleischner guidelines have low and high risk groups based upon patient smoking factor, but also radon and environmental exposures that can provide patients with a high risk category, family history, and low risk, those that lack those risk factors. And they separate into different nodule sizes with smaller interval follow-up as the nodules get larger in size. And nodules greater than 8, as we touched upon, the Fleischner guidelines recommend the PET-CT or the biopsy or the close follow-up. The key aspects I'd like to touch upon in terms of the Fleischner is that patients with any history of malignancy, the Fleischner guidelines don't apply. Fever may represent the etiology for the lung nodule if the infection is the cause, and subsolid lesions need longer follow-up. And here's just an example of a small nodule that I think we see oftentimes. But this patient did have a history of colon cancer, and we can see this actually proved to be more significant in this patient with colon cancer than if the patient was a patient without any history of malignancy and was just getting a CT for pneumonia, and this was incidentally detected. So small nodules can be very significant in patients with a history of malignancy. Now, I'd like to touch upon that these guidelines of Fleischner is really for incidental lung nodules and not for the screening scenario. I think we know about the lung RADs, which is a different guidelines, and there are multiple other screening guidelines. And the major differences I just like to keep in my mind is that the solid cutoffs are different in terms of nodule size between screening and the incidental as of now. And the major differences are in the subsolid, which we'll be hearing about. So in summary, I think we all know that there are some aids that we could implement to improve our nodule detection, but we reviewed where we overlook lung nodules on CT. Thin section really is key for evaluating morphology in terms of margin, shape, and also attenuation. Attention to dose reduction is something that we implement to minimize radiation exposure to our patients, and there are some current modulation techniques to think about and other aspects. And false negatives do occur with PET-CT and nodule enhancement if that's utilized, and therefore follow-up a CT of negative nodules by those modalities is recommended to avoid misdiagnosing cancer as a benign entity. And to keep in mind the decreasing nodule to continue following those lesions to long-term stability or resolution, and that there are cystic presentations, and there are exceptions to Fleischner guidelines. So with that, I'd like to thank you for your attention, and I think we will then move on to our next presentation, which is Dr. Godoy. Thank you.
Thank you. Good morning, everyone. It's my great pleasure to be here today to talk about subsolid lung nodules. So this is my disclosure. During this presentation, I will be reviewing the main characteristics of subsolid nodules and CT anatomopathologic correlation. We're going to go over differential diagnosis and management of these lesions, and then some persistent controversies about characterization of these nodules. So as you know, a pulmonary nodule on CT, it might be solid, this soft tissue lesion that completely obscures the lung parenchyma, or subsolid nodule, which includes these two types of lesions, the pure ground glass nodules or non-solid nodules, which are those lesions that do not obscure the lung parenchyma, as you can see here, with a vessel still visualized crossing the lesion, or also includes a part solid nodule, which is a mixed lesion that has a ground glass and a solid component. I want to emphasize that it's very important to use continuous thin section images to evaluate these lesions with slight thickness up to 2.5 millimeters, ideally 1 millimeter, so that we can precise characterize these lesions and assess for the presence and the amount of solid component, which can have implications for the management of these lesions and prognosis, as we're going to see later on this presentation. So our understanding of the importance of the subsolid nodules and its correlation with lung adenocarcinoma has increased during the last 15 years based on several lung cancer screening studies. And a study from the LCAP, for example, has demonstrated that within the 19% of the subsolid nodules that were detected, 34% of them were malignant versus only 7% of the solid lesions. So a higher likelihood of being malignant for subsolid nodules. And within the subsolid nodules, 63% of the part solid nodules were malignant and 18% of the ground glass nodules. And usually those malignant lesions correspond to lesions in the spectrum of lung adenocarcinoma. So in 2011, a multidisciplinary group from members from the International Association for the Study of Lung Cancer, the American Thoracic Society, and the European Respiratory Society presented a new classification for lung adenocarcinoma. And that divides the tumors into 4 major groups. One is the pre-invasive lesions, including atypical adenomatous hyperplasia and adenocarcinoma in situ. Then the next group is minimally invasive adenocarcinoma. And this group was created based on the knowledge that those lesions that are similar to adenocarcinoma in situ but have a small area of stromal invasion have an excellent prognosis similar to adenocarcinoma in situ with near 100% 5-year survival rate. So they created this new subgroup for these lesions with a very good prognosis to differentiate from the other invasive lung adenocarcinoma that have not such a good prognosis. And then there are also the variants of the invasive lung adenocarcinoma. And that are studies showing that there is a very good correlation between the CT features and the anatomopathological classification of these nodules. The pre-invasive lesions, the atypical adenomatous hyperplasia and adenocarcinoma in situ, tend to present on CT as pure ground glass lesions, whereas minimally invasive lesions might have a small solid component corresponding to that area of stromal invasion, or they can also present as a pure ground glass nodule if the area of invasion is below CT resolution. The other invasive tumors tend to present as part solid or solid lesions. And this includes the lipidic predominant adenocarcinoma, which is a prior mixed tumor with predominant bronchial-alveolar cell carcinoma of the non-mucinous type, according to the previous nomenclature. So these lesions, they also have a lipidic component similar to adenocarcinoma in situ, but they have an invasive component as well, greater than 5 millimeters, that tend to present as solid on CT. The other tumor, invasive mucinous adenocarcinoma, that was also previously called in the spectrum of bronchial-alveolar cell carcinoma, but the mucinous type, tend to be more solid on CT, either a predominantly solid lesion or a solid nodule or an area of consolidation, whereas the other types of lung adenocarcinoma tend to be solid. And because several of these lesions are mixed tumors, the majority of the adenocarcinomas are mixed with different subtypes, the nomenclature of these invasive adenocarcinomas will depend on the predominant subtype, such as Acinar predominant adenocarcinoma or papillary predominant adenocarcinoma. But those are the solid ones. And so, as you can see here, as we progress from the pre-invasive to minimally invasive to invasive lesions, the attenuation on CT will increase, changing from pure ground glass nodules to part solid to solid lesions, and the prognosis of these patients will decrease. So let's go over this classification in a little bit more detail. Atypical adenomatous hyperplasia is there a pre-invasive lesion, is actually also a pre-malignant lesion, is a precursor of lung adenocarcinoma. There is mild to moderate atypia of the pneumocytes. We can see those atypical cells here with some gaps between the cells. The lesion usually measures up to 5 millimeters and presents on CT as a small ground glass measuring up to 5 millimeters. Adenocarcinoma in situ is the new name for the former bronchial-alveolar cell carcinoma. This is also a pre-invasive lesion, but now with a higher degree of atypia, with these atypical cells going along the alveolar walls, but there is no stromal invasion, as you can see here. And this is the so-called lipidic growth pattern. These lesions also have, by definition, no vascular, lymphatic, or pleural invasion, so they have an excellent prognosis, 100% 5-year survival rate. To be able to make the diagnosis of an adenocarcinoma in situ, we need complete resection of the lesion because we need to be sure there is no area of stromal invasion. And the majority of these lesions are non-mucinous, but they can be mucinous or mixed. And as I mentioned before, they usually present as ground glass nodules on CT, and that's because the architecture of the lung is preserved. We can still see air within the alveolar walls, in the alveolar space, so that gives this translucent appearance of the ground glass nodules. And on PET-CT, they tend to have no FDG avidity, so this is a known cause of false negative on PET-CT. Therefore, if we see a persistent ground glass nodule, especially if it's increasing in size and attenuation, we should be concerned about adenocarcinoma, regardless of the FDG avidity on PET. Minimally invasive adenocarcinoma is that group that also has predominant lipidic pattern, but now there is a focal area of stromal invasion measuring up to 5 millimeters. And there is no lymphatic, vascular, or pleural invasion, so it's still an excellent prognosis. On CT, the ground glass corresponds to the lipidic pattern, whereas solid component corresponds to the stromal invasion. And again, for this diagnosis, we need complete evaluation of the lesion on histology. Lipidic predominant adenocarcinoma is a type of invasive adenocarcinoma where we again see predominant lipidic growth, but now we have an area of stromal invasion measuring more than 5 millimeters. And now we might see lymphatic, vascular, or pleural invasion, so not such as good prognosis. Again, on CT, we see a part solid nodule with the ground glass corresponding to the lipidic pattern and a solid component corresponding to stromal invasion. Sometimes this lesion might present as solid nodules as well, and rarely, in up to 7% of the cases, they might present as pure ground glass nodules, and in that case, mimicking adenocarcinoma in situ. So we have to be careful. There is overlap between the CT presentation of these lesions. Invasive mucinous adenocarcinoma is a variant by new classification. This is the former adenocarcinoma-mixed subtype that had a predominant mucinous bronchial-alveolar cell carcinoma. So this is the mucinous type. Here we also see a lipidic growth, but there is cylindric cells with abundant intracellular mucin, and we also see mucin within the alveolar space, and that gives the solid appearance of these lesions that are usually completely solid or predominantly solid. They might also present as areas of consolidation, as you can see in this case with multifocal adenocarcinoma. And finally, the other types tend to be solid. This is just an example of Acinar predominant adenocarcinoma, where you can see these oval areas of malignant glands invading the fibrotic stroma, and in this case, FDG avid. So besides the spectrum of lung adenocarcinoma, subsolid nodules can also have a benign etiology. They might be infection, focal inflammation, such as organizing pneumonia, eosinophilic pneumonia, or nonspecific interstitial pneumonia. They might also represent focal fibrosis. So the only way to differentiate is to follow up these lesions. A large percentage of these nodules are transient and benign, up to 70%. Younger age, elevated blood eosinophilia, and polygonal shape are some features that would indicate a higher likelihood that they are going to be transient. And here's an example of polygonal shape that resolved on a 3-month follow-up. But if the part solid nodules and ground glass nodules are persistent, then the likelihood of being malignant is pretty high. On a study by Kim and colleagues, 75% of persistent ground glass nodules were adenocarcinoma, whereas only 25% were premalignant or benign. And there has been some studies showing specific features that are seen in different types. For instance, sphericity has been seen more frequently in atypical adenomatous hyperplasia, air bronchogram, and size greater than 10 millimeters, more frequently seen in lung adenocarcinoma. but still there is not one feature that can completely differentiate benign from malignant nodules. So the only way is to really follow these lesions. This is an example from New York University where we can see ground glass nodules in the left upper lobe. On around 3 months follow-up, we see that these lesions had increased in size, although the attenuation has slightly decreased. This patient underwent left upper lobectomy, and this was focal non-specific interstitial pneumonia, so an inflammatory lesion. We can see in the alveolar septa some inflammatory cells without any atypia. Here's another case of bilateral part-solid nodules that could very well represent multifocal adenocarcinoma. In this case, it was biopsy-proven sarcoidosis. What about differential diagnosis in patients that have known extrapulmonary cancer? In this case, the likelihood of malignancy is also high, but most likely they represent primary lung neoplasm rather than metastatic disease. This is a case we saw in our institution with a right upper lobe ground glass nodule in a patient with ovarian cancer. So this was concerning for a primary lung malignancy. A 6-month follow-up was performed, and we can see now a solid component within this lesion. So it was biopsied but showed organizing pneumonia. To confirm for resolution or stability, a new follow-up was done in 6 months, but now we see solid component has increased in size. So our concern for adenocarcinoma increases, and a rebiopsy confirmed a primary lung adenocarcinoma. We've heard about the growth rate of the malignant lung nodules and the long volume doubling time for the subsolid lesions, particularly the ground glass nodules with average volume doubling time around 800 days. So several considerations are taken from this information. One of them, as mentioned by Dr. Koh, is that 2 years stability as a sign of benign etiology does not apply for subsolid nodules. We have to follow these lesions for more than 2 years, at least 3 to 5 years, and there is no significant data about long-term follow-up of these lesions or when we should stop following them. Other important information here is that we have to always make sure to look at the baseline CT for comparison, not only the most recent CT, so that we can better appreciate these low changes along the time. This patient, for instance, has a subtle ground glass nodule that was increasing in size and attenuation slowly over the years. Much better to characterize when you compare to the baseline CT. And here a resection showed lipidic predominant adenocarcinoma. And then finally, there is a concern for overdiagnosis because of the volume doubling time greater than 450 days, particularly for elder patients. And this is, would be the malignant nodules that would not have time to grow or to cause symptoms in patients during their lifespan. And therefore, we should be concerned about the overdiagnosis, particularly in lung cancer screening, and that is the reason why we have some different management that we're going to be talking later on. So what's the natural history of these lesions? The malignant lesions that initially present as ground glass nodules tend to increase in size in 75% in a study by Takashima and colleagues. And then a subset of them will present a solid component, which is then going to increase in size. So this shows that even though some of these malignant nodules are going to be stable or indolent, a stepwise progression from non-invasive to invasive lesions can be seen on CT, at least in a subset of these lesions. Let me show you some examples. This is a right upper lobe ground glass nodule. 3 years later, we see it has significantly increased in size. This was an adenocarcinoma in situ. Here's another case. We see 4 years interval, and the lesion has increased in size. Now we see a small solid component. This was a minimally invasive adenocarcinoma. And here another case, a very subtle ground glass lesion in the right upper lobe. 3 years later, we see now it has a more aggressive appearance with a solid component measuring more than 5 millimeters. Sometimes the overall size of the lesion does not increase significantly, but the solid component does, and that's a sign of progression and highly suspicious for malignancy. And just a word of caution, even though they tend to have this slow growth and more indolent behavior. That's not always true, and sometimes these lesions might present a more aggressive aspect, and that's why it's important to follow those guidelines and make sure to follow these lesions appropriately. In terms of prognosis, the percentage of ground glass corresponds to the lipidic component, and the solid area tends to correspond to invasive component. Therefore, the greater the solid component, the better the prognosis. And there are studies showing that lesions that have more than 75% of ground glass component tend to represent pre-invasive or minimally invasive tumors, and the better prognosis, particularly the ground glass nodules measuring up to 20 millimeters. So these lesions tend to have no nodal metastasis and no postoperative recurrences. And because of that, sometimes a limited resection is performed, including radial resection or segmentectomy, particularly for the ground glass nodules, and especially important for those patients that have more than one dominant lesions to be resected. However, the results from limited resection are still being investigated on clinical trials as compared to lobectomy, which is still the standard of care for lung cancer. Let's move on to how to manage these lesions. And there are different guidelines for solid nodules as presented by Dr. Cole, and guidelines for subsolid nodules that are incidentally detected, as well for those that are detected in lung cancer screening. One of the guidelines that we follow in our institution for incidentally detected subsolid nodules is the Fleshner Society guidelines published in 2013, and that's going to be the focus of this review. As an important difference from the Fleshner Society guidelines of solid lesions is that for subsolid nodules, we do not differentiate patients in high and low risk, and that's because of the high risk of adenocarcinoma in younger patients and those who have never smoked. And also important to emphasize that these are general guidelines, and we have to look at each case on a case-by-case basis, of course. So how do we follow them? If there is a ground glass nodule measuring up to 5 millimeters, no additional follow-up is needed. Most likely this represents atypical adenomatous hyperplasia. If the ground glass nodule measures 5 millimeters or greater, then we have to follow them. We do initial follow-up in 3 months. Several of them are going to resolve, but if they persist, we have to continue follow them annually with low-dose CT for at least 3 to 5 years. Biopsy can be performed, but we have to be careful with that. It can be potentially inaccurate or misleading due to the sometimes difficulty from pathologists to differentiate between the spectrum of adenocarcinoma in situ and atypical adenomatous hyperplasia, and also related to sampling problems from the biopsy being performed in the non-invasive component versus the invasive component of these nodules. PET-CT is unlikely to be helpful for ground glass nodules, as we saw before. They tend to be non-FDG avid. If we're following the ground glass nodule and there is an increase in size or density, or development of a new solid component, then resection should be considered. For part solid nodules, we tend to be more aggressive because the solid component might represent an area of stromal invasion, so we're more cautious and more aggressive with these lesions. We also do initial follow-up in 3 months, but if they persist, we should consider these lesions for resection. If the solid component is up to 5 millimeters, then a more conservative approach with annual follow-up is also acceptable, especially for patients that are poor surgical candidates. In this case, a PET-CT can be performed if the solid component measure greater than 7 to 10 millimeters, but it's usually more useful for staging rather than diagnosis in these lesions. Here's an example of a large part solid nodule in the left lower lobe. We can see that there was FDG uptake in the solid component of the lesion. And in this case, patient did not have signs of nodal or distant metastasis, so he underwent lobectomy. This was a lipidic predominant adenocarcinoma. Now, how do we follow multiple nodules? If they're all tiny, up to 5 millimeters in pure ground glass in attenuation, we do a follow-up in 2 and 4 years. If there are larger lesions, then we do initial follow-up in 3 months, and then we follow them annually. If there are dominant lesions, we can consider them for resection, and these would include the persistent part-solid nodules or ground glass nodules that are greater than 10 millimeters or that are particularly increasing in size and attenuation with development of new solid component. So here's an example of a patient with multiple subsolid nodules. We see a dominant part-solid nodule in the right upper lobe and other smaller ground glass nodules bilaterally. We have to consider that patients with multiple subsolid nodules are concerning for multifocal lung adenocarcinoma rather than metastatic disease. So the presence of contralateral nodules does not preclude resection of the dominant one or a few lesions, such as in this case. So a nodule was resected and the other ones were followed and were stable over time. However, if there are multiple nodules and resection is not possible, such as in this case, then a biopsy is usually performed with molecular profiling. And we know for adenocarcinoma, the most common mutations we can find are KRAS and EGFR, and they are useful for prediction of response to target therapy. Currently, up to 25% of the lung cancers are being treated with target therapy. And the EGFR mutation is the one that indicates that the tumor is going to respond to the tyrosine kinase inhibitors, which are the target therapy in this case. KRAS is most frequently seen in mucinous tumors and does not respond to target therapy, whereas EGFR tend to be seen in the non-mucinous lesions more frequently. For patients that underwent resection of a lung cancer, we also have to follow them annually for at least 3 to 5 years because they have a higher likelihood of developing new cancers. And this is a case of a patient that had a mucinous lung adenocarcinoma in the left lung and later on presented with a new ground glass nodule that progressed. This was also mucinous invasive adenocarcinoma. This is just an overview of the management of those incidentally detected subsolid nodules. So pure ground glass nodules measuring more than 5 millimeters are going to be followed, and if there is increasing size or new solid component, we're going to consider resection. Part-solid nodules, we do initial follow-up in 3 months. If they persist, then we are concerned enough to consider resection at this time. But if the solid component is pretty small, measuring up to 5 millimeters, we can also have a more conservative approach and follow them annually. If there are multiple lesions and they are all small and pure ground glass, we follow in 2 and 5 years. If they are greater than 5 millimeters or if there is a part-solid nodule, we do initial follow-up in 3 months. And if they persist and if we continue following. If there is a dominant lesion, a part-solid nodule that is stable or increasing, or a ground glass nodule greater than 10 millimeters or that is increasing, we're going to consider resection of these lesions. So what about lung cancer screening? Why do we have different management for those? Several reasons for that. One of them is that these patients tend to have age range being older than patients with incidentally detected nodules, and the age will depend on the criteria that's been used for lung cancer screening. But there is a higher risk of overdiagnosis because of the age. Also, we know that these patients are going to be followed annually because they are in a lung cancer screening. So we know we have at least a follow-up in a year to reassess these lesions. And also there is concerns related to public health, a large percentage of the population being screened with a large number of nodules being detected and the risks associated with radiation and invasive procedures for these lesions. So we tend to be more conservative with the nodules that are detected on screening. And there are different guidelines. The most recent one is the one from the American College of Radiology, the LungRads, which is a lung imaging reporting and data system that was created to standardize the lexicon, the classification, and the management of the screen-detected nodules. And you can access these guidelines in the website from the American College of Radiology. I just want to briefly review the management related to the non-solid lesions or ground glass nodules in a screen-detected setting. So if a nodule is less than 20 millimeters, or if it's greater than that but it's stable or slowly growing, we're going to classify them in LungRads2, which corresponds to benign appearance or behavior. So the importance here is that this not corresponds to benign etiology. We saw before these lesions have a high likelihood of being malignant, but because of their slow growth and because of they tend to be indolent, we're going to call them benign appearance or behavior, and we're going to follow them annually. If, however, they are greater than equal or greater 20 millimeters, or they are new, then we're going to classify them as probably benign, LungRads3, and we're going to follow them in 6 months. And again, it's probably benign behavior, not probably benign etiology. Here's an example. This was a LungRads2 measuring less than 20 millimeters. So we did annual follow-up, and here we can see that it's a slow increase in size. Now there's some solid component within it, and this was resected and it was an adenocarcinoma. Part solid nodules are also managed according to their size, as well as the size of the solid component. So if the solid component is greater than 6 millimeters, equal or greater, that's when we're going to start calling them suspicious. Or if there is a new solid component that is, a solid component that's new or is growing, measuring less than 4 millimeters, we again call them suspicious and follow them in 3 months. But if the solid component is equal, greater, or 8 millimeters, or if on follow-up we see that's new or growing, measuring 4 millimeters or greater, then we're going to call them LungRads 4B, and that's when tissue sampling can be performed. So the last thing I want to discuss is about some controversies about measurement of these lesions. And because of their poorly defined borders, it's hard to be accurate when measuring these lesions, and there is high inter- and intra-observer variability. So different methods of measurements have been investigated. One of them is the so-called tumor disappearance rate, which is the percentage of the area of the lesion measured on the lung window setting compared to the area measured at the mediastinal window setting. So we see what's the percentage that disappears, which corresponds to the non-solid part of the lesion. And if it's greater than 75%, then it's more likely to be an adenocarcinoma in situ or a minimally invasive adenocarcinoma. The use of computer-aided detection has also been investigated, and new softwares and prototypes have increased their sensitivity for detection of these lesions, and they have been shown to increase readers' sensitivity for detection of the nodules. However, they are still to be FDA approved. Automated or semi-automated measurements of the diameter, volume, mass, and attenuation of the subsolid nodules are also promising tools to increase our accuracy for measurement and assess for interval change. We can also use textural analysis and radiomics to be able to further characterize these lesions. This is a study from Maldonado and colleagues that used a software called Computer-Aided Nodule Assessment and Risk Yield to be able to characterize the level of tumor invasiveness, and the software was able to have a better accuracy to detect invasiveness as compared to the visual assessment by radiologists. And what about the effect of different types of iterative reconstruction on the characterization of the subsolid nodules? This is also still to be further investigated, but initial studies such as this one from Katsura and colleagues have demonstrated that using, for instance, in the study, model-based iterative reconstruction with ultra-low-dose CT as compared to low-dose CT with adaptive statistical iterative reconstruction was able to significantly decrease the radiation exposure to sub-millisievert levels without changing the overall detection rate of the nodules, and especially without changing the detection of the ground glass nodules and part solid nodules. Here's a case from that study, and you can see that even though the images look different, we can still characterize the ground glass nodule in the model-based iterative reconstruction. So in summary, subsolid nodules have a higher malignancy rate than solid lesions. There is close correlation between the nodule attenuation and the spectrum of lung adenocarcinoma. These lesions, they tend to be more indolent. However, in a subset of lesions, we can see progression going from the pre-invasive to invasive appearance in these lesions. And because of their longer volume doubling time, 2-year stability does not indicate benign etiology. We have to follow them longer, at least 3 to 5 years. And there are dedicated guidelines for management of both incidentally detected and screen-detected subsolid nodules. But again, we have to look at each case on a case-by-case basis. So thank you so much for your attention. And it is my pleasure to introduce our next speaker, a colleague of mine from MD Anderson Cancer Center. Dr. Brett Carter is going to be talking about lung cancer staging.
Good morning, everyone. It's a pleasure to be here. We're going to change gears slightly and move from nodules and identification of lung cancer to, once you have a lung cancer, how to stage this appropriately and how to relay this information to our clinical colleagues. These are my disclosures, which are not relevant to this talk. So the goals and objectives for this talk, we are going to start by outlining the staging system, the TNM system that we use for lung cancer. Once we outline that, we will look at specific TNM descriptors and look at examples of each of these. And then once you're all experts with regards to these descriptors, we will combine all of this into overall staging. We'll also talk about some of the limitations of the current system, and we will end by going over a series of unknown cases. So just a few words about lung cancer in general. As you all know, it's still the leading cause of cancer-related deaths for men and women in the U.S., and it is estimated in the year 2015 that lung cancer will account for 27% of all cancer deaths, and they estimate that there will be about 221,000 new cases diagnosed this year. So the current version of the staging system was published in 2009, and this was the result of the lung cancer staging project that was conducted by ISLAC. And they looked at several 100,000 cases of lung cancer and tried to associate certain descriptors with overall 5-year survival. And so these changes are based on that project. And so they made key revisions to the system, to the T and the M descriptors, but no changes were made to the N descriptors. Also, for the first time under the staging system, they recommended not only including non-small cell lung cancer, but also small cell lung cancer and bronchopulmonary carcinoid. So one of the key changes involved tumor size, and several of these specific descriptors, primarily T1 and T2, were actually split into specific components based on size, as we'll see. For instance, T1 was split into T1A and T1B based on size, with T1A measuring less than 2, T1B measuring between 2 and 3 centimeter. And similarly for T2 lesions, T2A is between 3 and 5 centimeters, T2B between 5 and 7, and T3 lesions measure greater than 7 centimeters. Some changes were also made to tumor nodules. As we can see here in this example, we have a primary lung cancer in the left upper lobe and a tumor nodule within the same lobe, and this is T3 disease. We can see this other lung cancer in the left upper lobe here, but we have a tumor nodule that's located within the same lung but a different lobe in the left lower lobe, and this represents T4 disease. Finally, we have this example of a lung cancer in the left upper lobe and a tumor nodule that is located within the contralateral lung in the right upper lobe. And this was biopsied, and this is actually the same type of tumor. So this represented metastatic disease, or M1A disease. Finally, the M descriptor was split into M1A and M1B components based on the location of metastatic disease. For instance, M1A is characteristic of mets that are located within the chest. So we're talking about pleural disease, pericardial disease, as well as tumor nodules located within the contralateral lung. And so we can see here on this example that we have examples of pleural effusions for pleural disease as well as a pericardial effusion. And then M1B basically describes mets that are located anywhere else that are not within the chest, as we can see here in this liver met that is FDG-avid on PET-CT. So we'll start by talking about the tumor designation and some of the factors that we need to consider whenever we are talking about tumor staging. Some of the characteristics that we look at primarily include size, and we usually use the long axis diameter for measuring these tumors. Some of this will depend on what protocol you're using. For instance, sometimes we're asked to measure tumors in 2 dimensions. One of the limitations of the current system is that they did not specify what plane to use on CT in terms of where you measure the tumor. I think most of us tend to use the axial slices. But if you actually use your other planes, sometimes you can actually find a longer, you can find some images where tumors actually will measure longer on, say, a coronal or sagittal image as compared to an axial image. We want to identify the location as well as whether there is invasion. And we also want to identify whether or not there are tumor nodules. And if there are tumor nodules, where they're located with regards to the primary tumor. So starting with T1 tumors, as we talked about earlier, T1 tumors have been split into T1A and T1B based on size. And this was due to a small but significant difference in the overall 5-year survival between these types of tumors. Similarly, T2 has been split into T1A and T2B based principally on size, with T2 measuring between 3 and 5 and T2B measuring between 5 and 7. And if any of these other features are present, this is also characteristic of T2 tumors. So we're talking about invasion of the visceral pleura, whether there's involvement of the main bronchus more than 2 centimeters from the carina, or if there's collapse of a lobe, or whether there's pneumonia in a lobe. But it's important to note that this denotes less than the entire lung involvement. And here we have several examples of T2 tumors. We can see on this image that we have this cavitary lesion within the right lower lobe that was a squamous cell carcinoma, a pretty classic appearance of that tumor. And it clearly measures greater than 3 centimeters but less than 7. So this is a T2 tumor. This lesion is present within the left upper lobe, and as you can see, it's right up against the interlobar fissure. So this was concerning for invasion of the visceral pleura, which can be difficult for us to be able to identify on CT, but at the time of surgery, this actually was present. And finally, we can see here that this patient has left upper lobe collapse. But we can see that within this left upper lobe collapse, that there are regions of hypoenhancement and low density, which was consistent with tumor involvement, and we can see abrupt cutoff of the left upper lobe bronchus. Moving on to T3 tumors, these tumors measure greater than 7 centimeters in greatest dimension, and also they are characteristic of satellite tumor nodules located within the same lobe of the lung. Also, if you have tumor invasion of any of the following structures, such as the chest wall, diaphragm, phrenic nerve. And here we have several examples of T3 tumors. We can see this primary lung cancer here within the right lower lobe, but we have a very small tumor nodule located in the same lobe, characteristic of T3. We have this very large tumor here that just, kind of on gross examination clearly measures greater than 7 centimeters. We have this lesion here that is located in the right lung that invades the chest wall, characteristic of T3. And then finally, we have this hypodense lesion here located within the left infrahilar lung that results in complete collapse of the left lung consistent with T3 disease. Finally, T4 tumors are characteristic of tumor nodules located within the same side or the same lung as the primary tumor, but a different lobe, as well as invasion of any of the following structures. So we're talking about some of the vital structures that are present within the chest, including the heart, great vessels, trachea, esophagus, carina, and vertebral bodies. And here are several examples of T4 tumors. As we can see here, we have the soft tissue mass that's located within the left aspect of the mediastinum that really surrounds the entirety of the left pulmonary artery and really narrows the pulmonary artery. And this was consistent with T4 disease. We have this lesion here that really occupies the entirety of the left hemithorax, which is probably a combination of collapse and tumor involvement. But we can see here that we have this soft tissue lesion that is actually extending through one of the pulmonary veins into the left atrium, consistent with cardiac invasion. And finally, we have this lesion that we saw earlier, which is a primary tumor in the left upper lobe, and then a satellite nodule or tumor nodule in the left lower lobe. So before I move on to the nodal descriptors, I want to spend just a few minutes talking about some of the limitations and with regards to the current system and tumor staging. And one of these involves trying to measure these lesions because, as you often see sometime in clinical practice, there are tumors like this that just kind of manifest as consolidation or some ground glass opacity and airspace opacity. And the question is, where would you really measure this? And you really can't, because it's hard to identify what part of this is tumor and what part could be hemorrhage or something else going on. In a similar case here, this is a patient who had a lung cancer in the right lung. And so this really, this opacity here is a combination of collapse and the tumor. So it's really hard to identify how large this tumor is in reality. One of the tools that we can actually use is contrast-enhanced CT and PET-CT to try and get an idea of how large these tumors are. For instance, here we have this region of opacity in the left lung, which could represent the entire tumor, but whenever we look at the contrast-enhanced chest CT, we can actually see this kind of vague enhancement here and some central low attenuation. So we kind of have an idea that this could be the actual tumor here, and then the opacity adjacent to it could just be something else entirely. And then we can see on the PET-CT that this region that does demonstrate some enhancement is actually FTG avid on the PET-CT, and so this actually confirms the presence, location, and size of this tumor. Moving on to lymph nodes, this really describes the presence or the absence of lymph node involvement in the chest, and that's an important fact to consider as we move on, because there are several nodal groups that may be in the chest but are not included with certain descriptors in the system, and we'll address that topic later. In contrast to how we measure the primary tumor, typically whenever we measure lymph nodes, we use the short axis dimension. And for most lymph nodes in the chest, we use a cutoff size of 1 centimeter, and so if a lymph node is greater than 1 centimeter in short axis, we raise concern that that could be nodal involvement. There are some exceptions. For instance, some subcarinal lymph nodes will actually say that those can get up to 1.3, 1.4 centimeters sometimes without being abnormal. And so here's the chart of the lymph node designations. And just some trends to point out overall, you can see that the more extensive the lymph node involvement, the poor prognosis, and the decreased overall 5-year survival. So we'll start with the N1 disease, and this typically are lymph nodes that are located within the ipsilateral hilum or the interlobar regions. N2 disease is subcarinal lymph nodes, or lymph nodes that are present within the mediastinum on the same side as the tumor. And N3 disease can be lymph nodes that are present within the contralateral mediastinum, the contralateral hilum, or the supraclavicular regions, regardless of side. One note is that in the course of conducting the lung cancer staging project, they noticed that there was a difference in 5-year survival based on the number of nodal groups that were involved within some of these designations, such as N1 and N2. And as we can see here, these patients who had several lymph node groups involved, they had a worse prognosis and an overall worse 5-year survival. So we'll look at several examples of lymph nodes. We can see here in this first image from this PET-CT, we can see this lymph node within the right hilum in a patient that had a right lung cancer is FDG avid, and this was consistent with N1 disease. However, it's important to note that on the CT image, there was no lymph node that was identified in this region, so this is actually one instance where PET can be very valuable. Moving on to N2 disease, we can see the primary lung cancer here within the right lung, as well as this very enlarged right paratracheal lymph node, consistent with N2 disease. And finally, this image is of a patient who had a right lower lobe lung cancer, which we don't see on this image here, but there was this enlarged right paratracheal lymph node, which by itself would just be N2 disease, but the fact that we have this enlarged lymph node within the contralateral mediastinum makes this N3 disease, so this is much more extensive. So as we mentioned earlier, there are certain nodal groups that may be involved in non-small cell lung cancer, but are not really addressed within the current staging system. And some of these groups include axillary, subpectoral, internal mammary, diaphragmatic, and some of the upper abdominal lymph nodes. And these are, like as we mentioned, do not have a specific descriptor mentioned in the staging system. And so some of the practices may vary based on location. For instance, some places will consider the presence of a lymph node in the axilla to be N3 disease, whereas some people will consider subdiaphragmatic lymph nodes to be M1 disease. So we can see here in this example that we saw earlier of chest wall invasion, this patient actually has this enlarged right axillary lymph node, and so this was actually staged as N3 disease clinically. On this whole body PET image here, we can see that this patient had a right lung cancer that had been treated, so we don't see any evidence of tumor within the right lung. But at their follow-up PET-CT, they actually had this lymph node within the right inguinal region that did demonstrate increased FDG uptake and was positive by biopsy. So this was actually staged as M1B disease. Moving on to metastatic disease, a large portion of patients who present with non-small cell lung cancer, almost half, will actually have mets at the time of staging. The most common sites we can see include the liver, brain, bone, and the adrenal glands, as well as the lung, whether it's the same lung or the contralateral lung. And it's important to note that just because the patient has metastatic disease does not mean that they cannot have their primary tumor resected. If, for instance, if they have very limited nodes, then they may actually have those nodes treated with chemotherapy and then have their primary tumor resected. So the metastasis designation has been split into M1A and M1B components, as we discussed earlier, with the M1A components consistent with mets that are within the chest, such as pleural or pericardial metastases, as well as tumor nodules that are located within the contralateral lung. And M1B will denote anything else outside of the chest. And so here we'll see several examples of thoracic metastases. This first example is a patient who at the time of staging CT, had a lung cancer in the right lung, and they had this small right pleural effusion, but there was nothing that was within the pleura itself in terms of nodules that was concerning for pleural metastases. But we can see on the PET-CT that they clearly had this region that does demonstrate some increased FDG uptake, and this was biopsied and was consistent with metastasis. A similar case here, this patient has a very hypodense and large pericardial effusion consistent with metastasis, and they also have small pleural effusions. And finally, this patient has a primary lung cancer within the right upper lobe and has this irregular nodule here within the left upper lobe that was biopsied, and this was consistent with the same type of lung cancer consistent with metastases. And so finally, here we'll see several examples of distant metastases. We can see here on this brain MRI, this peripherally enhancing lesion within the right cerebral hemisphere consistent with metastasis. The second example is a patient who had some very nonspecific thickening of the right adrenal glands, and it was kind of indeterminate on the CT whether this represented metastasis or hyperplasia. But we can see on the PET-CT that this region did demonstrate increased FDG uptake, and biopsy later showed metastasis. And finally, we can see here, which is a relatively common site of metastasis, is the liver, and this patient with non-small cell lung cancer had this very large lesion within the liver that was FDG avid, consistent with metastasis. So one of the limitations of the current staging system is that it does not discuss differential fiber survival based on the number and extent of metastatic disease. And just kind of based on our clinical experience, and I'm sure yours, you've noticed that patients who have different kind of metastases will respond differently to treatment, and their prognosis is overall different. For instance, this is a patient who had this primary lung cancer in the right lung that we can see here. And their only site of disease outside the chest was this REM-enhancing lesion here within the brain. So this patient actually had their right upper lobe lung cancer treated with radiation therapy, and they had their MET resected. And so that patient is actually 5 years out of therapy and is doing very well. Similar case here, this patient has a primary tumor that is FDG avid within the right upper lobe, and their only other site of disease was the right adrenal gland here. So similarly, this patient had their right upper lobe lung cancer treated with radiation therapy, and they had their right adrenal MET resected. And this is a PET-CT follow-up 3 years after therapy, and they're still doing very well and have no evidence of recurrent or metastatic disease. And we can contrast that with this patient here, who, as you can see on this PET-CT, really had mets throughout their entire body. And so clearly there is a difference in the overall prognosis based on the location and the number of metastases. So this is a potential source of something that could be addressed in future staging systems. So here's an overall summary of the TNM system. This is in your handout if you want to use that as a reference at some point. Really what I want to point out is that the stages that are highlighted in green, between 1A and 3A, generally are considered resectable disease, whereas those that are 3B and 4 that are highlighted in red usually are not. There are some exceptions to this. For instance, as we discussed, if a patient has extensive T4 disease but has a very low stage of nodal disease, sometimes they can be treated with chemotherapy and then actually have their primary tumor resected. So we'll end our session today by just going over a handful of cases, just to kind of show you some different examples and some potential pitfalls. In our first case here, we can see this lesion within the left upper lobe that is T2B because it clearly measures greater than 3 centimeters, but is not 7 centimeters. We can see on the same CT that this patient had this subcarinal lymph node that, as we talked about earlier, was a little bit on the prominent side, but it was around 1.1 centimeters. So for us, that was kind of indeterminate. But we can see on their PET CT that it was very FDG avid. And this lymph node was biopsied and was consistent with metastasis. So using all of this patient was actually 3A, and so they were able to receive chemotherapy to treat their lymph node and then had their primary tumor resected. Our next case, as we can see here on this coronal chest CT, we can see that they had this primary lung cancer within the medial aspect of the left upper lobe that actually extended through a pulmonary vein into the left heart. However, they had no nodes and they had no mets. So this is another example of a patient who was able to be treated with chemotherapy to actually shrink this tumor and then have this tumor resected. Case 3, we have this very large tumor here that just kind of on gross inspection is clearly going to be a T3 at least, just based on the size, which is clearly greater than 7 centimeters. However, if we look at the remainder of the study, we can see that there's this enlarged right paratracheal lymph node consistent with N2 disease, but we can also see that there's a pleural met here within the right hemithorax consistent with M1A disease. So overall, this patient is stage 4, so this patient would not be a surgical candidate. Case 4, as we can see here, this patient has a very large tumor that's located within the left aspect of the mediastinum that does result in an invasion. So based on that alone, we have T4 disease. And we can see several lymph nodes that are enlarged within the mediastinum, including this left paratracheal lymph node, as well as this right paratracheal lymph node. So this patient has N3 disease. And if we look in the upper abdomen, they also have this left adrenal met, consistent with M1B disease. So overall, this patient is also a stage 4, and they would not be able to have their primary tumor resected based on these criteria. Our last 2 cases here, we can see on this coronal CT image here, we have this very large mass in the left aspect of the chest that does result in some invasion of the thoracic spine, which you can see here. So based on that criterion alone, this is T4 disease. However, we can see that there is this other nodule located within the right upper lobe. So this was actually biopsied, and before the results came back, we assumed that this would be M1A disease, and this was all the same tumor. But this was actually 2 different tumors. The tumor that's very large, that's located within the left lung, is actually a squamous cell carcinoma, and the tumor that's present within the right upper lobe is actually a small cell lung cancer. So it's important to note that whenever you have 2 different lung cancers like this, that they each have to be staged separately. And here's our final case here, and this is kind of similar to the previous concept, and then we have 3 very different looking lesions here on this coronal CT. This first lesion here in the right lower lobe was actually a small cell lung cancer. This more solid looking lesion here in the left upper lobe was a squamous cell cancer, and this ground glass lesion was a KRAS mutation for adenocarcinoma. So here, we can see that this patient clearly has 3 different looking lesions, and they're all 3 different primary malignancies. So it's important to note that whenever you see things like this, that sometimes your clinicians may come to you and ask you to biopsy several lesions so that they can stage these patients appropriately. And here we have another example of several adenocarcinomas. So hopefully you would not be asked to biopsy all of these lesions, but that you could tell them that this was most likely going to be several different adenocarcinomas, and that could be left alone. So in conclusion, it's important to remember that lung cancer is the leading cause of cancer-related mortality in the U.S. Really, the purpose of really kind of having a grasp on the staging system is so that we can really add value to our patients and to our clinical colleagues, because obviously what we say on these studies will impact ultimately how they're treated. Thank you very much.
I think there are a few minutes for questions, if there are any from the audience.
Hi. The introduction of LRADs compared to the Fleischner criteria in two different populations, I think, is really injecting a tremendous amount of confusion. I'm in private practice, in my practice and the community in general, especially when it seems to me you're applying a little less restrictive follow-up criteria in a more high-risk population, the screening population, compared to these incidental nodules. And maybe I still don't understand the rationale for doing that and how we're going to explain this to the medical community.
So I agree with your statement. It is confusing, and hopefully later on we're going to have more similar guidelines. But one of the reasons is for that difference is we have on the screening population, they are a higher risk for active lung cancers, for aggressive lung cancers, but those adenocarcinomas that are more indolent, they are seen on a higher percentage in younger patients and non-smokers, especially Asian women about 50 years old. So this is the population that has those more indolent tumors. It's just different from the smoking, high-risk smoking
No, I understand that, but why would you follow ground glass opacities differently in the two populations? I mean, they both have a likelihood of becoming cancer. So why would you follow, just based on morphology alone, why would you follow it less aggressively in the high-risk population? That's what I don't understand.
Yeah, but you have to also consider besides that they have a higher risk for aggressive tumors, but they have also a high percentage of those ground glass nodules that tend to be more indolent. So there is potential to have more overdiagnosis in that group.
Okay.
And then we're also talking about a high percentage of the population and innumerable ground glass nodules that we're going to be seeing. So if we're going to do 3-month follow-up in all that population, so that increases the cost, increases radiation. So that was a way to try to decrease all these concerns that are related to the screening, so that the screening becomes acceptable.
But there's a whole bunch of practical considerations that are going to make this a nightmare. Mm-hmm. Insurance companies, private coverage, right. Differences between Medicare coverage.
Yeah, it is
I
very
hope you can
complicated.
Work it out. Right.
I think the guidelines are I guess they evolve with increasing knowledge, and it is acknowledged that there is the two separate populations, and it does get confusing. And I think the one aspect about lung cancer screening is that those patients, as per the CMS guidelines, are invested in definitely following up. And I think particularly for the solid nodules, in addition, is that the size criteria is a little bit more generous for the lung rads. And the reason is that those patients have invested in a decision-making process to continue the screening process, to follow up, as opposed to those patients in which they're incidental nodules. And then there's the overall risk to the population for the cost-risk benefit. So it's agreed that there are these two guidelines that at this point can be confusing, and hopefully as knowledge increases, then they'll evolve.
I have a statement and a question. I want to thank you for 3 very wonderful talks. And I hate to highlight a single case, but this did happen to a group of us. I believe in the Fleischner criteria for solid nodules. It said 4 to 6 millimeters. If it's unchanged after a year, then no further follow-up is necessary. Is that correct? With no prior history of cancer or no prior risks.
We're talking about solid lesions?
Solitary nodule, right. Anyway, I think that is the case. So I just want to bring it to the attention of the audience that we were sued, 4 of us were sued, for a 4 to 5 millimeter solid central nodule right next to a vessel. And it was not perceived by 4 different radiologists on 3 different CTs that were done over, let's say, they were done over 2 years. Then the patient came in and had, with chest pain, a little bit later, and had a CTA for PE, and it showed up on the coronal. And it turned out that, so we went the whole route. And I'm only, I only have one lesson I can take from this. But it was 4 years of interrogatories, depositions. It went to trial. We won, there were 8 jurors, and we won all 4 of us, 8 jurors. So 32 decisions were on our side. But that doesn't mean that you don't go through all kinds of anxiety. And then the attorney appealed the case. And so we had to go through the whole anxiety thing again, and thank God the higher courts refused to hear it. But it took them about a year to even look at it, so we had no idea. So the only message I can take is when I saw that, when it says don't bother getting a follow-up CT on a solid nodule between 4 and 6 millimeters, I would suggest you might want to get one in a year, you know, and maybe even another. But just, you know, I hate to have one case, you know, affect people, but it really did affect us a lot. The question I have, the irony of this case, is that it essentially came up because one person who, on one of the later scans on the CTA, that individual did not have, was at another hospital. So then the patient came back to us. So they didn't have the priors. The patient came back to us, and the person who was evaluating the case for a potential biopsy actually said that the lesion did not look like it had significantly changed from the priors. So my question to you was, what brought that whole suit around was because this other person mentioned that there were these prior CTs and the nodule was there. How do you dictate, when you're reading and you see a nodule, an 8 millimeter nodule, whatever, solid, and you look back and you see something really subtle, how do you dictate that?
I think one point that I would to make is that these nodules, the malignant ones, they're going to start at some point. So we do see some nodules, 3 millimeters, that turn out to be later on cancers, either if they're solid or ground glass. So we use the size threshold, but there will be those that are smaller than those thresholds. So one thing that I do is, when we're talking about follow-up, we say according to guidelines from Freshness Society or according to guidelines from the American College of Radiology. So that is not your management. This is accepted medical management based on the knowledge we have at this point. Regarding your question, we have to be very cautious on when we see those retrospective lesions. So one thing that we could potentially say is barely identifiable. Previously, I don't know if you guys have other suggestions.
There are some times where if something hasn't been called before, I will actually just say there is a nodule measuring X, and will not throw the person under the bus who came before me who didn't talk about it. And then once I do that, then I'll call the clinician and kind of alert them to what's going on. So then if they do go back and look at the previous ones, then they kind of have a heads up in that regard.
Thank you.
Okay, so I'd like to thank you all for attending the session, and we'll be around here if any of you have some additional questions. So thank you very much.